Thank you. Good morning, everyone. Welcome to Southern. We're delighted to have you. It's nice to be in a room and actually having a hot breakfast together. Those days seem like they were an eternity ago. But I'd like to welcome our elected officials, Mayor Donchis, as well as all of our community partners. I think that this is a great representation of all the different collaboration that goes along in the community to make everything work. And I want to thank Bobby for her leadership. She's the glue that keeps a lot of this together and has been an enormous help to me here at Southern as its new leader. I'm now in my 8th month, and someone just said to me I picked a great time to come in and try to lead a healthcare organization. We are having significant challenges, as we all know. We're talking about an incredibly important topic this morning, but every day, healthcare organizations, including our community partners, are really working hard to try to meet the needs with increasingly scarcer and scarcer resources. So every day we have hundreds of patients accessing our health system, and we have an incredibly committed workforce and group of clinicians that work hard to care for these patients and make sure that they're getting everything that they need. But there are many gaps, as we all know. So every day we have hundreds of people coming through our ED or our immediate care centers across greater Nashua, and we have a lot of need out there right now. We provide primary care services to well over 80,000 people, and every day is a effort to make sure we're providing the right amount of access and care for people. So it's a heavy lift, but we're doing it, and a lot of it is because we're able to work together, both as healthcare organizations and as community partners. Also wanted to just mention briefly, we've had a significant commitment to behavioral health and substance use here as a health system. We currently operate the Doorway, so we're very appreciative for that opportunity. We serve hundreds of people, and we do our best to place people across the community. We also treat hundreds of patients through our partial hospital programs and intensive outpatient programs, and we also operate an inpatient unit. So we're very much into this. This is a core part of our mission as an organization, and we're going to continue to invest everything we can into meeting the needs of the community. So without further ado, I'd like to turn it over to the meeting at hand, and looking forward to a great morning. And again, thank you and welcome to Southern New Hampshire Health.
Well, Bobby tells me it's my turn, so here I am. It's really early. Well, first, thank you to Southern for hosting us again. It's always nice to get together here at your facility. It really works out well. And I want to thank all of you for coming to join us for this 5th annual legislative breakfast of the Mayor's Opioid Task Force. Before we go further, I'd like to thank Bobby for organizing us, as well as our public health department and public health nurses for working so hard, not only on the opioid crisis, but on COVID and all of the other health problems that we've had over the last few years. COVID for 3 now. We formed the Mayor's Opioid Task Force in 2016 in order to create a network of organizations and individuals, and of course you're here today, to work together to stop overdose deaths in Nashua and improve access to substance misuse services throughout the continuum of care. So our efforts, working side by side together, resulted in the creation of a 3-year strategic plan for prevention, which was released then in 2019. The reduction of substance abuse in the region was identified as the top priority. The task force, you all, have worked together since the height of the opioid epidemic to implement innovative solutions for prevention, for recovery, and for treatment services to address this priority of the strategic plan, which is, of course, to reduce opioid deaths. Since the pandemic began, 3 years now, We have seen the number of overdoses and suspected overdose deaths fluctuate up and down every year. According to AMR, who keeps detailed data on all of this, this is a quote, suspected opioid ODs during 2022 here in Nashua were at 243, which is a 15% decrease from the previous year's 285. While that is welcome news, the number of deaths rose to 44, which is a 37% increase from the previous year of 30 suspected opioid overdose deaths. And they go on. The fewer number of ODs that did happen in Nashua were significantly more lethal on a per capita or population basis. So that's AMR's observation. So we obviously have the continuing challenge of seeing new substances which come into the community, starting with, it started with prescription opioids, which drove the substance and began the substance misuse problem several years ago. That was followed by heroin, then fentanyl, and now the sedative xylazine, which does not respond to Narcan and has increasingly been identified in a growing number of opioid deaths. As a community, we all play important roles in substance misuse prevention, everyone here. Today, our task force would like you to think about substance misuse services through the lens of workforce capacity and its impact on access to life-saving treatment, early intervention, and prevention services. So I want to thank you for taking your time to join us this morning. Thank you to our panelists, which we're very anxious to hear from. And I want to thank you for helping us and learning with us to make Nashua an even healthier community and place to live. So thank you all for coming.
Good morning, everyone, and thank you for being here. Thank you, Colin, for having us, and thank you, Mayor, for that introduction. Welcome to 2023, and if this is my first time seeing many of you, which it is, Happy New Year. It's going to be a better 2023 because it's going to be better together. I want to thank our planning committee, which includes our behavioral health team, and Mackenzie Variu, who is a part of our public health department from the CDC. I want to welcome our legislators. Can I just see a hand of our legislators that are here? Thank you. And our aldermen. Thank you. Our community-based participants that work in substance use, misuse, disorder. Thank you. Mental health. Thank you. Behavioral health? Yes. Thank you. Community Health Center? Thank you. Public health? Thank you. You know, okay, so when I say public health, actually every hand should go up. So I'm going to say that one again. Public health. All right? You all make up the public health system. And the reason why I say better together, because in order for us to see the changes that we need to see, it's going to take all of us working together to do this. This morning, we have a fantastic panel of subject matter experts that are going to talk about our future, moving forward in our future. I wanted to share some data before they got started, because when we think about forecasting our future, we have to think about what's already happening and what we already know. So just some quick data points. The mayor read some data about what we've seen with our opioid epidemic, substance misuse in our community. I just wanted to share some data from the Women's Foundation report that came out in December. And this is important because when we talk about workforce capacity, we have to have people to do the work. So our panel is going to talk about the things that impact those things. Right now, we have, as far as mental health, 66% of women struggle with anxiety, and 48% of men are struggling with anxiety. 28% of women experience depression. 15% of men experience depression. For substance use, 29% of deaths were in women, of 102. 71% of the deaths were in men, 252. A total of 354 opioid-related overdose deaths occurred in 2020. Non-opioid-related overdose deaths, 37% of those deaths were in women, and 63% of those deaths were in men. Heroin and other opioid treatment admissions, 39% of those admissions were women, 61% of those admissions were men. Alcohol use treatment admissions, 32% of those admissions were women, and 68% of those admissions were men. Domestic violence survivors, 92% of domestic violence survivors are women, 8% of domestic violence survivors are men. There's been a 15% increase in the number of crisis calls to domestic violence crisis hotlines, a 16% increase in the number of individuals who were provided shelter at domestic and sexual violence centers. Other important data, when we look at the mental health provider ratio in 2021, there were 283 people per one provider in Hillsborough County, and 288 people per one provider in New Hampshire. Population living in poverty in 2021, 5% of the greater Nashville Public Health region lives in poverty, and 7% of New Hampshire overall lives in poverty. Why is data important? Because this is what we need to know about our community in order for us to make efforts to make some improvements. I'm going to turn it over to Lisa Vasquez, who is our behavioral health strategist, who's going to facilitate our panel as we have this discussion on forecasting our future. I also want to make you aware of, the mayor mentioned the Mayor's Opioid Task Force started in 2016. This group has continued to meet on a monthly basis to address what we're seeing with our opioid, with our mental health and behavioral health issues, to come up with strategies to attack this issue. Because we know that it's more than just opioids, the Mayor's Task Force is now going to be called, drum roll, the Mayor's Task Force on Substance Misuse going forward. And so I know we love the motive. We can still call it the motive, but it'll be the Mayor's Task Force on Substance Misuse. Thank you so much for being here this morning. Better together for 2023.
Thank you, everyone, and good morning. I'm Lisa Vasquez. I'm the Behavioral Health Strategist for the Division of Public Health and Community Services, and I also am one of the facilitators of the Mayor's Task Force on Substance Misuse. And I am going to introduce these wonderful people here today that are going to give us a little insight of what is going on in different sectors of our community. I'm going to start just by saying their names and their titles. So Susan Mead is the Community Educator and Outreach Director at the Greater Nashville Mental Health Center. Elizabeth or Eliza Blondeau is the Emergency Department Case Manager at St. Joseph's Hospital. We have Colleen Flynn, Director of Patient and Family Service at Southern New Hampshire Health Systems, and Dr. Cynthia Whitaker, President and CEO of Greater Nashville Mental Health. I will just give them about 5 minutes to talk a little bit each of what they're seeing in each of their respective places of work, or the places where they see the community most.
Okay.
There you go.
Thank you, Lisa.
So in terms of the mental health center, what are we seeing is we are seeing a rise in need, right? I'm certain everybody knows that to be the case. But while that is happening, we're also, of course, experiencing similar staff shortages that others are experiencing. Actually, if you want to show the next slide, it would be awesome to show that right away. So this is for the 10 community mental health centers, and it's just a visual. Greater Nashua Mental Health is one of 10 community mental health centers across the state, and together we form the Community Behavioral Health Association. And that chart shows that our staff budgeted positions since 2020 has grown every year. But while that has grown, so has our vacancies. And so we're all trying to budget to create space to address the need, but at the same time experiencing challenges with staffing to do so. So that's a big kind of general thing that we're dealing with, and just kind of excited to be here today to talk about that more and answer any questions that folks have.
Good morning. My name is Colleen Flynn. I'm the Director of Patient Family Services here at Southern New Hampshire. Thank you for joining us. Here at the hospital, you know, we start meeting with the patients as soon as they arrive, and kind of look at how can we make connections from the hospital out into the community. What we see is a growing population, an aging population in Nashua, as well as a population that is coping with substance misuse. As we try to make a recovery successful plan, it's about connecting them back to community services. And as Dr. Whitaker was saying, it's with the limitation in staffing in those areas, it makes it difficult and delay access to having those people make those connections, which results in a potential, you know, loss of word, sorry, you know, another event that involves a rehospitalization. The hospital deals with capacity. And again, we have limitations with, you know, throughput, with, you know, increased needs in the, you know, because again, there's lack of access to community resources. So we work with all our partners here in Nashua, as well as the surrounding areas in Hillsborough County, to try to service all the needs of the area. But we do see the shortages having a significant impact, from transportation to placement to reconnecting them back to their community programs.
Hi, my name is Liza. I'm the nurse case manager at St. Joe's Emergency Department. I am also a trained psychiatric nurse, and I've been working in mental health for about 10 years. I deal with similar things, obviously. Obviously similar issues. Both Nashua hospitals face a lot of the same challenges. In the emergency department, it creates a bottleneck if there's not the appropriate resource to get people back out, and there's sort of a mismatch of available resources versus what my patients need. So I face a challenge with handicapped accessible shelters, handicapped housing first type shelters where people sort of burn bridges at the regular shelters, and there's no shelter to send someone that has a substance or alcohol use history. The higher acuity substance use treatment programs, for those in the biz, the 3.3 and above, for people that are Medicaid subscribers. If someone has commercial insurance or Medicare, I can send them out of state, but if they're Medicaid, if there's not a program for someone that has an intellectual disability and a substance use disorder, I'm stuck. If someone needs a detox program for alcohol and benzodiazepines, I can't send them anywhere. They end up being sort of an avoidable hospitalization because we have to monitor them for safety. So we're looking at more expensive dispositions and inappropriate dispositions just based on a mismatch of availability of resources. I would also say with intellectual disability and serious mental illness, there's not a lot of programs and options. I feel like they're a hot potato where mental health world says this is related to their intellectual disability. You know, the DD community says, oh, that's mental illness, and no one wants to really provide the services that would help them be successful in the community. And they may end up in places like group homes, which, as in my training, you always want the least restrictive setting that keeps someone safe, and so we're we're sort of putting people in nursing homes and group homes that could be successful if there was other types of supporting programs out there. And then the people that really need the group homes and nursing homes are waiting on wait lists for beds. So this mismatch, I think, is an ongoing concern. The traumatic brain injury from people being resuscitated is underestimated, and there's not really a program. There are some sprinkle of programs, but they do need a different type of programming to accommodate the brain injury from anoxic brain injury. And so so then they're more likely to relapse if they don't have the right supports, because their brains don't think the same way anymore. They've got some of that executive function damage. So I see all these things every day, and I really don't always have the opportunity to match them up with my ideal disposition for them. And so that would lead to, again, relapse, coming back to the ER, challenges with them keeping up in a household and bills in the community. There's a lot of things that are impacted by that.
Good morning. I'm Susan from the Mental Health Center, and I've been there for 36 years. We now hire people younger than years that I've been working there. But, and I'm hired under what's called PATH grant, Projects to Assist Transition from Homelessness. And it's a federal grant from SAMHSA, that is Substance Abuse Mental Health Services Administration. And we have not, they have it a formula grant, and it started in 1991. And basically my role is to help those engage in services who might have a mental health issue or mental health and substance misuse disorder, who are homeless or at risk of being homeless. We have not had an increase in funding in this area since 1991. The state gets $300,000 to split, and not all the 10 mental health centers even has a PATH worker going out into the community. So that's one thing I ask, and I thank the legislators for being here. I understand you have a fast learning curve, so I'm going to give a quick down dirty history lesson. In 1975, when JFK, the president, mandated that we should have mental health across the country, we deinstitutionalized the state hospital. We had 2,500 beds. Now we have 150 beds at the state hospital. And the pendulum really swung. And I noticed folks were getting arrested and going to jail. We really didn't have options. I helped create the initial mental health court in this region. And when Judge Leary took it over, it mushroomed. We diverted so many people who had mental health issues going to jail, but getting them back into treatment. So much so that the jail then gave us a liaison in the mental health center in Manchester and Nashua to try and continue to help divert folks into treatment. What's beautiful about Nashua is I have a lot of community partners out here. And we work well together, but when you have folks who are needing psychiatric services, languishing in the EDs. I called last Thursday. There are 49 people in the state of New Hampshire now waiting for a bed at a psychiatric hospital. Do the math. In the emergency department rooms, these folks are staying there for probably 7 to 10 days at whatever cost that is, waiting for a bed at a psychiatric hospital. New Hampshire Hospital, another hat I wear is the state hospital liaison, and they are used to not discharge to shelters, and now they're forced to. So now you're putting that kind of pressure on shelters dealing with folks who have mental health issues. Nashua has a 1% vacancy rate. Who's going to rent to our folks who make $800 a month? And I really think the legislators back in 1975, when they created the 10 Mental Health Center, was very foresight in their thinking. It returned the mental health back to their communities near their families. What hasn't happened, and I think in the bigger picture, is they didn't count on the cost of housing. Who is going to rent to our folks who need to have these issues? And I really think the state needs to help us more. We have lots of housing programs, subsidy programs. There are 130 vouchers now in the hands of our clients that can't find an apartment. Those, I mean, these are real, no one wants to talk about the affordable housing because it's really not popular, but somehow the state needs to we need to work together. Again, back to how we do work together, I sit now on an encampment meeting, and Nashua PD, I see my partners over there, Nashua Fire, City Nashua Welfare Director, Environmental Health, Public Health, and Community Services are at that table. Department of Public Works is at that table. Nashua Soup Kitchen Shelter attended, and so do a few of the outreach workers. We're working together to try and address some of the homeless issues. And I was asking Deputy Chief Fay in the audience what he sees, and what he sees as the homeless issue are the folks who are dealing with substance misuse disorders, mental health disorders, and or the combination of both of those. So it behooves us to work together, because I think we're losing money where we could definitely reallocate monies for folks and helping housing our folks. So I thank you again. You have a quick learning curve, and I really think we can do something about this. And I'll just throw this out there, but this is a betting state. Why not create a housing lottery so that we can start raising money somehow? There has to be some give here to address this issue. I really think it's a focus that is missing. Thank you.
Thank you to our panelists for their updates on the state of workforce capacity in their respective fields. I want to just bring everyone's attention to the index cards that are in the middle of your tables. They are for questions, so if you have questions at any time, please write them down. I'll have Mackenzie, Leah, and Liana pick them up. Just raise them up, and they'll bring it up at the end of of the assigned questions. We'll open it up to audience questions, and we'll read them then. Thank you. So we might think that the issue of the mental health center or the hospital is just like an issue for the mental health center and the hospital, but in reality is all of our issue. It's a community issue. It is the issue of every person who's actively looking for treatment services. It's really a state, a country issue. We're a small state in comparison, but we deserve timely access to services just like everyone else. So I'm just going to open these questions up to any of the panel members or all of the panel members. In your experience, how has workforce capacity impacted the priority issues in your organization in behavioral health, substance use disorder, housing, and homelessness?
It doesn't like to turn green, does it?
No, it doesn't turn green.
It doesn't turn green.
Use your outside voice.
Use my outside voice. Oh, there it goes. Certainly for us, even pre-pandemic, pre-challenges with workforce, to the point that they are now, I mean, we've certainly always had some behavioral health workforce challenges, even pre-pandemic. One of our priorities has been to improve access. So pre-pandemic, we started a program, a program called Open Access, where people can just come in and get an evaluation on that particular day. And what's happened is we've been able to continue that program when many of our sister community mental health centers actually closed theirs. But what happens is now people have a little bit of a wait to actually get their first appointment after that intake. But what we chose to do was to still allow open access and to still have that appointment, because what we can do is we can evaluate people, and if there's a real crisis need, we can get them to crisis services quickly. If maybe their need for those in the substance use disorder world is at a higher level of care, we can refer them to one of our partners rather than having them wait 2, 3, 4, 5, even 6 months at some other places for an intake appointment. So for us, workforce really impacts access to care.
So I'm going to use my outdoor voice.
Yeah, it's not working.
So for the hospital, we see two distinct age groups. We see the young age group that is coping with substance misuse disorder that suddenly comes into an extreme medical crisis, and that changes the trajectory of their life. And some of them are uninsured, and as the hospital system tries to advocate, it's a long and lengthy process to get them into an insurance program and then evaluated and into extended programs that will support them, such as the brain injury program. When the hospital is dealing with days and weeks to try to transition, some of these agencies are so understaffed that what they're saying is it's going to take months before they can even start an intake process. And then once they determine the needs of the individual, it takes additional months to locate the staffing to support that individual. So we don't feel that that's a successful program, and so we continue to work with the programs. The state Medicaid programs, all companies, WellSense, New Hampshire Healthy Families, Amera Health, they all work with us. They all have liaisons in the hospitals, and we try to make connections through their agencies and their resources. But again, there's just not enough. So when we're dealing with the younger population, it's a big change in their lifestyle, and accessing services is a limiting factor that results in them being in the hospital much longer, because we want to have a successful transition and hand off so that individual can be as successful as possible. Then we swing to the other end of the spectrum, which is our older population that are suffering from years and years and years of alcohol misuse. And what we see is suddenly, to Sue's point, they've been shuffled through multiple agencies, multiple community programs. However, their capacity continues to languish. And then suddenly they show up at the hospital, possibly with a medical crisis, or they're in need of withdrawal treatment, and then we determine that they lack capacity. Now, this individual has probably been lacking capacity or lacking organization of life skills for a long time. They enter into the hospital. We have no discharge plan. So we start seeing individuals 45, 50, 60 years old, which are, still very young and very vibrant age group. However, they don't have insurance, or they do have insurance, but the insurance to get them long-term support is a 5-year look back. Now, these individuals have not kept very good records for 5 years. And they don't have the capacity. So we first have to start with guardianship. And we have to identify a guardian that can take over. And then once they take over, they start looking for what I call the needle in the haystack. All their resources, all their documentation, their financial documentation. I know that in New Hampshire, our Medicaid system is a full review of this 5-year look back, but we really have to look at changing that criteria. I understand it's a federal program and there's federal mandates to how it is managed, but we do know that there's a certain population that we can't identify financial resources. But I can say that the average person that comes in that lacks capacity and needs services, resources, and insurance, it takes me about 4 to 6 months to move that patient. So that's 4 to 6 months they're here in the hospital. There's no other resource, there's no other community transition. Sometimes in that 4 to 6 months, since they've gone through a detox program with us, about 2 to 3 months in, they could regain capacity. If they regain capacity, I'm bound to let them make a choice to, we can continue to help them and connect them with services, but again, there's no easy handoff, there's no immediate handoff. And so they go back out to the community, they might go to the shelters, but their behaviors, and it's hard, I think, for our workforce. It's a younger professional workforce, a lot of inexperienced nurses. They came into nursing, and all of our clinicians all came into the field to help people, and sometimes it doesn't feel very good to let them go out and say, good luck. And so we see that burning out our workforce. Pre-pandemic, I can't say staffing levels were exceptional. We were better than where we are today, but we know that the pandemic pushed a lot of aging staff members and experienced staff members into early retirement. They just said, I'm out. And then what we have backfilling into those positions is very inexperienced people, very, high goals, want to do well. But again, we just here don't have the supports to make sure that you're handing them off to a good system.
I can add to that. I deal with a similar issue in our hospital. I did take a look at 22's length of stay, some of the people that were in the hospital, the longest that were actually avoidable hospitalizations. So the longest one was 280 days. The holdup was a nursing home. I mean, the Medicaid look back was actually a holdup for 19 of them. But the city was assessing a mobile home at one value. The park, it was on leased land in a park. The park was saying it's going to be bulldozed and pulled away in a dumpster. It was condemned, holes in the floor, things like that. So on paper, it looks like someone has an asset that's uninhabitable, and what do you do with that? So you have to fight back and forth. So so there was about 48 of them in this situation where it costs us as a community, as taxpayers, resources that could be better spent elsewhere. I estimated about $6.5 million were spent on this avoidable care, which would have been less than $1 million in the community under Medicaid in the appropriate assisted living, supportive housing, nursing home type care. Obtaining public guardians for these people that have lost capacity. 8 of them were related to that, and then once you get the guardianship, then you can't do it all together. You can't start the Medicaid application without the guardianship in place. So we create one barrier after another that creates a bottleneck, and this is while we've got this nursing force that's burning out because we've been at full to the gills surge capacity, boarding admitted patients in the ER for 3 years now. And what I could estimate was 860 patients could have been in and out, medically necessary patients could have been in and out in that time with those beds if there wasn't people just stuck languishing in our departments because we couldn't get them out because there wasn't the right community resources for them to get where they need to go.
I guess I'd like to make the comment that since COVID, I think at least mental health is now able to be talked about. And the Surgeon General will tell you 1 in 5 of us will have a major mental illness during our lifetime. And I'll tell you it's 1 in 1, given enough stress. We all have our breaking point, right? So I think that the more compassion we can show to that population, to ourselves, we would have a better community setup. I'm going to harp on the affordable housing. I am now visiting people at motels who can't get into shelter because it's not handicapped access. I just visited a gentleman this week who had his other leg amputated. And he struggles, and he's in a hotel. He doesn't have a kitchen. And it feels wrong. I feel like we can do a better job. We have land, we have resources, and I think if we re-look at having folks languish in the EDs who have a psychiatric illness waiting for a real psychiatric bed, that would certainly free up a lot of their time. And these folks shouldn't be in the ED. They're not getting the psychiatric treatment. They're probably getting a combination of meds to keep them behaviorally calm.
Over-medications, ruined circadian rhythms with insomnia, social isolation, no diversional activity, so their cognition and functional dependence continue to get worse. So by the time we actually get the resources in place, they are going to need that highest, most restrictive level of care because they haven't been in the right placement for months.
Did I hit a spot?
Yeah. I'm a little passionate.
As a state, we are very reactive to crisis. Yes. We see high volume of funding for very specific issues with many restrictions, followed by times of low funding for the same issue once the spotlight is no longer on that issue. How does short-term funding affect your ability to respond to issues, and how is that related to workforce capacity?
Well, they pay us so much at the mental health center.
Yeah, you stayed for 37
I did stay. We are down, I think, 32 staff. We serve, what, 5,000 people. We're down 32 staff. So that we can, as Cynthia said, we can bring people in and get them assessed, but you're waiting 3 months for a team, which is, you know, that's frustrating to me. As the outreach worker bringing somebody in for services, I know there's a wait list there. So I'm staying on a case. I have a revolving caseload, as it were. When I feel someone's better connected, I can move on to something else. But I am working more with adult protective services than ever, you know, and it's screaming help for this population. So again, I think we have the right partnerships here. I think this community keeps coming together to try to brainstorm, and yet we don't have the fundamental resources for our folks making $800 a month to live here. It's really, it's financially, if we look at it, it's logical, but I think it's not popular. I don't think landlords, somehow landlords, it's difficult for landlords to take on some of our folks. I understand that. And a lot of them have colorful histories. I get that. But it doesn't mean that treatments are working. And when people do have that support and are getting diagnosed, we know more about the brain. We know more about how to help folks at this point. So there's this fear of taking folks on, and yet it's still an issue. So the fact that folks are being discharged from a state hospital, the highest restricted level of care, to a shelter is just, it's not conscionably the right thing to be doing.
So prior to my position here at Southern New Hampshire, I've worked in Nashua. I'm a long-term nursing home administrator, so I understand both spectrums. You know, in New Hampshire, the model for long-term care services is community first, nursing home last, because nursing home, to all our county budget expenditures, you know, is one of the highest costs. It costs more to put a person in a nursing home. However, saying that, and recognizing my partners that work in long-term care, they're not making money hand over fist as well. And the New Hampshire model is we have home, we have hospital, and we have nursing home. If you look at our counterparts in Maine, Massachusetts, Vermont, they have multiple level of models, you know, that it's not just being at home or hospital or nursing home. They have group homes, they have assisted living, you know, they have congregate, you know, communities, more housing available. You know, I believe Vermont just is building almost like a tiny house community is what I can see. But that is a challenge with our community resources. The other day I helped manage a care patient, and the answer is Adult Protective Services called. He's like, she needs a nursing home. How can she be successful? She's entitled to 40 hours of care in the community through the Choices for Independence waiver. She gets 8. How can you be successful and be successful at home? So there is a misnomer you know, and I apologize to our legislators, you know, that the people are being cared for by the waiver, and the waiver is doing the best, but they can't secure the labor it takes to take care of them. And these individuals are not, they're medically complex. They have many comorbid conditions. They have mental health issues. You know, we use the word they're not compliant. I never like to say that, because I like to say, what did we do to help them be successful? And if you don't have the resources, you can't be successful. So what we see in the hospital is that those individuals are being challenged. They can't have enough services to take care. They're readmitted. On the other side is that the hospital, when we have a patient that's readmitted over and over, the insurance companies do not reimburse us. Right. So it is a readmit penalty. And so we don't get any payment. And so then we have to appeal and fight. And again, it's because the lack of community. And so we're going to make sure that patient is safe. We're going to take care of them. And we're going to try to regroup with our agencies and see what we can do. But if they come back in 30 days, it starts all over. And to Sue's point about the housing, we do a lot of rehab at the hospital because, again, we work with our shelter partners because that might be the only avenue for them to go to temporarily. You know, we wait for a bottom bunk, we help them do stairs, we do as much as possible, and then they get to the shelter, it's like, I can't take care of myself. So the shelters send them back to the hospital because they don't feel it's safe for them. So we are the stopgap. and we're doing the best we can. But to Liz's point, you know, today, Southern New Hampshire has 15 individuals with us today that are all waiting for various guardianship, Medicaid placement. 3 of them have been waiting for Medicaid approval for over a month. Now, I believe the Executive Council just voted last week that anybody that had an application put in, they are going to move it forward because they're recognizing they don't have enough staffing to process these applications. If applications have been sitting on case managers' desks since December. So again, you know, we are taking care of the individual, we're keeping them safe, but what we're working in days, the state is working in a much longer time frame. And they're safe, so sometimes I feel like there's no hurry. And there's just nowhere to go. And then our nursing home partners, they have staffing shortages, you know, and then they have an experience. And again, they have beds open. We have about 1,000 beds open throughout the state of New Hampshire in nursing homes. They can't be staffed. So that's 1,000 beds. And they don't have to stay there. They can be a temporary holding until we can arrange appropriate resources in the community. So.
One of the things that comes up for me listening to both of you and your question, Lisa, is we've almost become complacent with Band-Aid fixes, right? And so we fund the Band-Aid fix, and then it's like, oh, right? Like, so all of our hospitals created pods to hold mental health patients in the ED, and we celebrated that. Like, that's a Band-Aid for a problem that shouldn't even exist, right? And so how do we, instead of saying what problem can I solve and stick a Band-Aid on it, right, can we ask the question of what should the system look like, right? I mean, what different answers do we find when we ask that question instead of how do I solve the ED boarding problem, right? You solve the ED boarding problem by creating a pod, by adding more staff, by creating a partnership. But what should our system look like? Right? You answer that question with funding that's long-term, that's transformative, that allows partnerships, and there isn't the, well, if you pay me more, you got to pay Greg less, and that should not be the transformation for the system that we're looking for. So, Lisa, when you ask that question, the short-term versus the long-term, I get passionate about that because I really think we've become complacent. Oh, the hospital will hold them. The mental health centers will continue to see them. But eventually, we're not going to be here because we're not going to have the staff to hold the Band-Aids together anymore if we're not funded the right way.
All right, I'm going to skip some questions for time, but what is the impact of Medicaid expansion on workforce capacity?
Everything and anything. Actually, if you want to go back to the slide from us, I did put some numbers on about Medicaid expansion and Medicaid. So Medicaid funds for the 10 community mental health centers range from either 60% to 90% of our entire revenue. Again, so changes to Medicaid truly impact our workforce, our ability to pay staff, our ability to provide services. So Medicaid expansion in 2022, there were over 11,000 people in our state that received mental health outpatient services on Medicaid expansion. 30,000 people through Medicaid expansion received mental health medication services. 9,000 people on Medicaid expansion in 2022 received SUD services. What is going to happen to those people without Medicaid expansion? They're going to come and they're going to get piecemeal care, maybe. They'll apply for charity care, and instead of getting medication that they then can't afford, they're going to end up in crisis, and we're going to continue this spiral of using EDs and hospitals to treat people we could be treating in the community and community mental health centers or FQHCs. This story is very similar in our FQHCs, you know, the impact that it has on them as well. So that's my answer to your question, Lisa.
I'm going to just do one last question and then we'll open it up to the audience. What is your wish for future support of workforce capacity and access to service? The miracle question. What do you want it to look like?
I guess what I asked is that we truly understand the value of our workforce and our systems and be compensated not based on a fixed budget, but on a budget that takes into what are the community needs, and that we completely assess fully, and we are compensated for our value, that our employees can also be compensated for their expertise and value. And so that is my wish, that the budget gets open, and I know that's very altruistic, but it's a wish, and that's all I can ask for, is full compensation for our services.
And I can add to that, we have plenty of New Hampshire schools of nursing and social work and mental health services, and if these individuals can go over the border in Massachusetts and make a decent living wage, or go into private practice instead of community mental health, then we're doing something wrong. And so right now, you know, one of the things I think of is incentivizing scholarships and tuition reimbursement for students, not just at the master's, nurse practitioner, and licensed social worker level, but the bulk of our mental health workforce in the community level is bachelor level. So why don't we incentivize keeping these bachelor level providers in the community? Free tuition for nurse assistants and support workers, or a reimbursement once they complete the course and they're employed by a community mental health center, that sort of thing to keep the workforce in New Hampshire would make a difference. I just see, like I said, we've got this brain drain, and we do have great schools and great programs, but if they can jump down to Lowell or Lawrence, then why not?
And I would just comment that we've lost many clinicians who come for 2 years to get their
Reimbursement?
Their training, and then they go out on their own.
Yeah.
And so we're down clinicians, but because we're not able to pay that competitive wage,
yeah.
like those right across our border. And my wish list would be of varying stages of housing. I'm just going to beat this. From the state hospital, sometimes they do have Philbrook, PATH, Philbrook, what's it stand for? Help me out. Sorry, PATH. Philbrook Adult Transitional Housing. Versus my path is Project to Assist Transition from Housing, just to mess with us. But we need different levels of care, right? I mean, from the transition from a nursing home level, from the hospital to a nursing home. There's sometimes even a graduated, not a hotel, and that's what we're using. That's what we're using now. So again, we need a graduated sense of housing to independence. It would be my wish.
I have a long wish list, you might imagine. A couple that rise to the top for me are short-sighted quality incentive programs. I mean, Colleen, you mentioned actually being penalized for good quality care. We had a transition from one of the hospitals into our mobile crisis unit, our crisis apartments, because that person at that time didn't really need what we thought inpatient level of care. While that person was with us, that person had got some news that was really activating for that person, and their mental health tanked. The first person we talked to at the hospital was hesitant to take the person back, because they knew it was going to hit them, the readmit. But then we worked together, and we figured it out. Got that person back in the hospital. They were able to re-stabilize temporarily. We provided care while they were waiting in the ED, and we pulled them back out. But they got penalized for good quality care. They got penalized for working with a partner. That is just wrong. That is so wrong. So that's a big wish list for me, is that our quality metrics wouldn't penalize us. That our quality metrics would actually measure long-term things outside of just one silo. So yes, it's not good when people come back to the hospital. But if they don't have a community partner to work with, it's not their fault. So we have to actually put that money that we're penalizing them into community work. Otherwise, it's not going to happen. So that's a big one for me. And Another one for me is definitely related to this wage gap that we are experiencing. So there's a wage gap, as Liza said, between New Hampshire and our sister states. Maine, I mean, just made a dramatic increase to their Medicaid rates, dramatic. That's going to change not only now our Mass border, but our Maine border, because their community mental health centers and FQHCs just got a massive Medicaid expanded rate. You know, what does that look like for us? How do we decrease that wage gap so we can keep people working to support what we need here in New Hampshire?
Anyone have a question from the audience? Yes.
If you have a question, can you just raise your hand so we can go to your table and pick them up for you?
Or a comment?
Can I just say something while we're collecting cards?
We don't have an extra.
It's okay, I can talk, can I talk really loudly?
Talk in that direction.
You don't have a mic on you.
Oh, okay.
Is this one? No? Oh, that's.
Oh, well, attempt that one.
Which is the mic?
You could try that one, but it ain't gonna work.
All right, here's a question. Are there conversations happening with our educational system to incentivize students to explore career opportunities in behavioral health services?
I mean, there are. They're probably not enough. So there are some, especially in the nursing field. So my counterparts might know more about that. But it's not enough. So still a lot of internships aren't paid. Still a lot of clinicals aren't paid for. So even though we might create a loan repayment, people still have to take the loan and not make money while they're going to school. So there's still a lot of gaps, even though those conversations are happening.
I can say as a nurse, when I was a nursing student, there was a mandatory psychiatric substance use clinical rotation, not as long as a med-surg rotation, but I had the opportunity to learn about mental health and experience it, and it's what made me want to go into mental health nursing. Those rotations are being eliminated from a lot of nursing schools because it's not necessarily required. You know, it's 5 or 6 NCLEX questions. And so and even back then, there was sort of a stigma. When I said I really want to go into mental health nursing, the med-surg nurses go, oh, really? You want to do that? I could never. And so there was almost a stigma about going into mental health inadvertently by the educators because they're so hospital acute care med-surg oriented. So there really is a huge you know, like workforce shortage of trained psychiatric nurses who have a passion for the career because they don't get that experience at the beginning when they're getting their education. So somehow encouraging that would be really helpful in our nursing schools.
Thank you. I have another question. Housing with assistance for older adults that have mental health and substance use treatment is absent. People have been barred from shelters and hotels. Where can they go other than the ER or the streets?
If you know the answer, let us know.
It's Massachusetts, it's
Yeah.
Maine, it
Yeah.
should be here in New Hampshire.
Right, there
With
certainly
free
isn't enough supportive
overtime.
housing. With both substance use and homelessness, if there's someone that has a self-care deficit, meaning they might need help with lower body dressing, use a rolling walker, may need assistance out of bed, we are dead in the water. There is no real resources for this type of individual, and this is their baseline, so we can't get them into a rehab. It's not appropriate. It's definitely a problem.
One of the things I would add is there's some regulation requirements that make that hard in our state. So as a whole, all 10 community mental health centers this past year created over 60 beds of supported housing for folks in our state. Here in Nashua, we added 9 instead of the required 6.
but I have to certify those beds in certain ways, and certain requirements require certain staff and so I actually cannot take anybody that requires medical assistance or has active SUD into those programs. And in fact, if somebody relapses and needs SUD treatment, I have to kick them out of that program because of the regulations by the state. So again, yay, state, we put funding toward supported housing by the community mental health centers, but short-sighted, not long-term fix by requiring us to follow certain regulations that don't allow us to take the very people we actually need to take.
And I can add to that. I did a stint as a home care nurse, and if I went into a home, I could go in there for mental health. I was a psychiatric nurse. I could go in, primary diagnosis is a mental health disorder. If I identified a substance use issue in my initial assessment, I'd have to actually discharge them, disqualify them from the program. So people that actually had a skilled need for home care would be disqualified from home care, which is insane. You would think once you have that identified that you would connect them to the appropriate resources and keep them in the home and continue, but that's just not how the regulations work.
I'm gonna go into the next question because I feel the passion of yeah.
That's why you asked.
Got the right panel.
Lack of Medicaid to obtain services is extremely difficult in obtaining, it is difficult in obtaining Medicaid in the state. Any suggestions to ease the difficulty and speed up the process?
I believe the Council on Aging committee that just reported in September is suggestive of presumptive approval, meaning that certain qualifications are met without the complete 5-year look back. Because in this population with substance misuse disorder and mental health disorder, to navigate finding those, all the documents for 5-year look back, divorce decrees, death certificates of a spouse, statements, and if you, and most,
Cash in CD, I mean, the list is really insane.
And if the individual was deemed to demonstrate in the 5-year look back that money's moved of a certain amount, and then state denies, the appeal process is the state has the burden of proof to demonstrate the individual used that money for the intent to qualify for Medicaid. And I really, and I've been doing this for 25 years, I've yet to have anybody say, I want to go to a nursing home and I'm spending all my money. So I firmly believe that presumptive approval would be a, certain qualifications, certain age groups and so forth would help expedite the individuals that really need to be connected to the community.
Great answer.
And I can add to that. If they are already on a Medicaid, like healthy families, they've already done a 5-year look back at some point in time. So they've already qualified for Medicaid once. If they're living in HUD housing and they've already demonstrated at some point in time while they still had capacity that they did not have this vast estate hidden from the state. So here we are, they're in the ER, they need long-term care, and we're jumping through hoops 200 days later trying to do this look back, trying to find these proofs with someone that's probably not had capacity for 3 years or any sort of knowledge of how they were spending their money. And so I think that's the presumptive eligibility would be extremely helpful. I also think if there is a concern, signing off on a lien against the estate or something, so if something does pop up later on, just detach it. That will be a part of how it's funded. But it is a real problem. This Medicaid look back is a huge barrier to getting people to where they need to go.
And folks who are homeless don't have abilities to keep their files in order.
Right, 5 years of statements right here on my backpack.
and trying to help somebody just to get their Social Security card or an ID. They have to get their Social Security card first, but they had to have medical discharge paper that had their social security number on it. It took me a month to get records from somebody from a hospital. And then if they were less than 2 years old, they wouldn't accept it. And during COVID, nobody went to the hospital. So this gentleman, an amputee, could not get a social security card because we couldn't get the records needed. It's just ridiculous. And now he can't apply. He has a voucher, but without that social security card and non-driver's ID, I can't get him in there to get the actual voucher. The basic information they need. It's very hard. And for when you become homeless, you're in survival. Yep. And it's not about keeping all those records straight. So I think we need a little more compassion to help this population.
Yeah.
Affordable housing as a HUD definition references individuals making up to $80,000 a year in Nashua. Low-income housing and workforce housing are stigmatized. Would it be helpful to identify the term maybe fixed income housing so that legislators understand what population is identified and advocate for it?
Just in brief, Section 8, we are waiting 8 years once you sign up to get a public housing and or Section 8. So 8-year wait list. People say, forget about it. I'm like, no, do it now, and you'll get on that list. Then they do everything by mail. So if you're transient and you lose your mail, you get dropped from that list. So I think we really need to look at this issue in another comprehensive way.
I'm just in the interest of time, we're going to wrap up. There were a lot of other questions. I thank everyone for your questions. I thank you for your time attending this morning. I hope you found the event educational. Please don't let this conversation end here. If you want to be part of the mayor's the mayor's task force on substance misuse, please let us know. We can put you on the list. If you want to be part of the continuum of care for homelessness, please talk to someone from that committee. We do talk to each other a lot. These issues are not going to go away unless we all put on our boots, put on our gloves, put up our pants, and get out there and do the work together. So please continue the conversation. Workforce capacity is a big issue wherever we want to provide timely access to service, quality of service, we need educated professionals to be able to do that. So we all deserve to have quality of care and quick access. Thank you again for coming, and again, don't let the conversation end here. Is there any legislator that wants to say something before we wrap up?
I want to thank you guys for having this. I know this morning there's the first meeting of the House Special Committee on Housing. Leader Wilhelm called for that in December. We're hoping we can take some positive strides on that and really get to the root issues of the lack of workforce, because we know it's vital. Medicaid expansion is going to be a priority for us, and it's going to be coming from the Senate. We'll be seeing that in May, and of course we all know how necessary that is for everyone's health here in the state, and primarily for the people that you all serve. I just want to point out, as you all know, nothing happens without money, and unfortunately there are continued attacks and cuts on state revenue. Just yesterday there was a bill that was presented to, they've already transitioned out the interest and dividends tax, which brings it over $150 million a year. It'll transition to zero in the next 5 years, and yesterday there was a bill filed that would get rid of it immediately as soon as possible. So, we're fighting an uphill battle that I hope many of you can understand also. But I want you to know that we are listening, we're hearing. We're just going to be starting the budget process when the governor hands it over to us on February 15th. And I'm hopeful that we'll be able to tackle some of these issues, but I encourage you to please stay engaged with the legislative process and keep us educated. So thank you for having me.
Thank you.
Thank you. And one last, one last comment. The earlier people get access to services, the better outcomes for the person, and the less expensive services need to be provided. So we're looking for ways to save money. Early access is really the way to go. So thanks. Thank you, everyone. Thank you.